Welcome, everyone. So we're here to talk about egg freezing today, and we have Dr. Chanel Adams, Dr. Rachel Danis, Dr. Sophia Visanji, and Carly. I'll let them introduce themselves.
I'm Dr. Adams. I am one of the Bios Fertility Institute providers. We recently merged with Kindbody. I'm located in the Pacific Northwest, specifically in the Vancouver, Washington, and Portland, Oregon area. It's where I was born and raised. And tonight we're going to be talking about egg freezing, and I'm really excited because I have my lovely patient with me here, Carly. We kind of met about a year ago, and it was a wonderful journey. And then this is also my colleague, Dr. Danis.
Hi, I'm Dr. Rachel Danis. I'm one of the reproductive endocrinology and fertility specialists at Kindbody for New York. I also work in our Princeton office in New Jersey. I've been with Kindbody for about a year. It's been a great experience, a great ride, and I'm excited to do this with Dr. Visanji and talk about our experience together.
Hi guys, I'm Sophia. I was a patient at Kindbody. I went through the egg freezing process last month with Dr. Danis, and so I'm excited to chat more about my journey.
And then I'm Carly, like Dr. Adams introduced. I live in Chicago, and I went through the process about a year ago, a little less, like 11 months ago.
Okay, I'll get started. So welcome to Kindbody. Kindbody's mission is to provide quality care to women all over the country now, thanks to merging with Bios. And our goal is to not only increase awareness of reproductive health and provide access to GYN care, but we want to just educate and provide the utmost reproductive health care we can to women. Next slide, please. So we offer not just egg freezing, we have many different services that we can offer both in person and virtually for both men and women actually. And our goal is to treat an infertile couple as a whole. So we can do fertility assessments for a single woman. We can talk about fertility care for a couple. We also work with reproductive urologists for men. We offer gynecology services. There's a whole list. We also have a holistic health department that provides virtual visits for nutrition and therapy. So there's a wide variety of care that you can get at Kindbody. Next slide, please. So like I just said, Kindbody's mission is to increase awareness of fertility care, reproductive health, and also provide the best services possible for patients all over the country. Next slide, please. So we think that this is a really important event because we want to increase awareness, send out information, and who else better to do that than not just the doctors who are providing the care, but patients themselves. So Sophia, why don't you start?
So I had been thinking about egg freezing for a really long time. I am turning 34 soon, and I'm a professional and not married and know that I want children. And so I probably started looking into egg freezing when I was 31. I went to different clinics. I had the follicle count done and all the blood work. And it was still always like you have a little bit of time. You could wait a couple years, maybe wait till next year. And finally this year I was like, it is really affecting my life because, it's like you're kind of in a rush to like find a partner and settle down. And there's all this pressure. And I was like, I think by going through this process and freezing my eggs, it's just that insurance policy, and it was like that little bit of security that I needed. So came into Kindbody. It was probably the third clinic I went to, and everyone was just so friendly and so kind, and the energy was just so amazing that like the second I had my first consult, I was like, this is it. Like, this is definitely the place that I want to go through this process with, because it just felt just warm. The environment was so great. And so I started my journey beginning of March last month with Dr. Danis. And you don't really know what to expect, because it's like with egg freezing and fertility, I just feel like they can be taboo topics, which is why I'm doing this, is because it's like I want other women to learn about it and for us to have these conversations, because a lot of people don't have the conversation, and then you go into it and you're like, I don't know what to expect. I don't know, like there was all this fear about like, how are the hormones going to affect my body? Like, am I going to gain weight? Like all of these things. Did the injections hurt? Like there's all these questions I had. And so, yeah, I think we need to talk about it. I think this conversation is so important. I had a great experience at Kind Body. And so I'm really happy with how things went. And since then, it has taken so much pressure off. You know, it's just felt like a huge relief, you know, that I don't have to worry about this. I have another birthday around the corner. And it's like, it's just that little bit of security for myself that's been so wonderful. So, yeah.
Okay, Carly, you're up.
Sophia, I relate to so much of what you said as, you know, a working woman. And I started this process, or started thinking about it on my 30th birthday. I went out to dinner with my aunt and uncle, and my uncle got up to use the washroom, and my aunt immediately was like, let's talk about freezing your eggs. And I was like, wow, I did not think this would come up on my 30th birthday, but here we go. And I learned from her. She also was a career woman, and she tried to conceive later in life, and her IVF journey was unsuccessful. And she was like, the one advice I give you is, you know, be that career woman. And, you know, what can you do now if you do want to have kids, or you're, you know, start a family later? And so it got me thinking. And then about a year later, two of my friends, they're twins who I grew up with, who also live in Chicago now, went to Vios to freeze their eggs. And I was like, this is the sign I needed. Like, thank you for doing it. So I know where to go and who to chat with. And, you know, did a consultation with Dr. Adams. It was wonderful. I felt really safe and taken care of, like as a woman surrounded by women encouraging me to look into this and do this. And I think I had my consult almost a year ago. I ended up harvesting July 2nd. Or July 1st. I'll always remember it was, you know, right around that holiday of July 4th. So I had to kind of sit at home and relax. But yeah, I did a lot of things to prepare for it. You know, eating healthy, taking vitamins. I did some IV drips, vitamin booster shots, everything I could kind of do, knowing that I really wanted to prepare my body and like essentially have my eggs be as healthy as they can. And yeah, I enjoyed the process. The shots weren't as bad as I thought they would be. I don't know if you felt like that, Sophia, but like day 1, I had anxiety, and by day 11, I was like, oh, this is old news.
Yeah.
And then I did have a friend who's a nurse do my trigger shot for me, because the needle was just, you know, a little large, and I'm single and I have no one living with me to do it for me. So Mimi did come over and do that, but retrieval went really well. I felt really good about surgery day, everything that went along with it. And I would do the process again. I liked it that much. And I would 100%, same as you, recommend that, like, if you're able to, and whether or not you are ready to have kids, or you're single or coupled up, whatever, it just feels so empowering. I never felt pressure from my family to like settle down and have children, but whatever pressure was there was relieved. And I feel like, you know, I can go into meeting my, you know, future partner, husband, whatever, without the pressure of the timeline on my body. So really, really empowering.
Thank you so much for sharing, Sophia and Carly. So now we'll start at the beginning. Dr. Rachel Danis, do you want to kick us off?
Yeah, so getting to that timeline, it's real. We actually, as women, are in utero. So when our mothers are pregnant with us at about 20 weeks of gestation, or about 5 months of pregnancy, that's when we have the largest number of follicles, and a follicle is what contains the eggs. So we have the largest number of eggs ever when we're not even born yet. And then we think that's about 6 to 7 million number of eggs at that time. By the time we're born, we have actually like 1 to 2 million eggs. By the time you hit puberty, it goes down to about 300,000 eggs. There's a wide range, as you can see by this slide. So time, unfortunately, is not on a woman's side. And once we start puberty, every month we're recruiting and losing follicles. So egg freezing is great because you can hang on to, or literally freeze, eggs for the future. Next slide, please. So both quantity and quality matter. What do we mean by this? Well, if you come for an assessment, we'll assess your fertility, which there's no perfect math calculation to assess someone's fertility. You don't get like a 2% out of 100. You don't get an A plus versus an A minus, but there's a few different components, and we focus on both quality and quantity. Unfortunately, there's no great test for egg quality, but it does go down with age. And what I mean by egg quality is the ability of your egg to actually make a baby at the end of the day. We know that as egg quality declines or goes down, it's harder for sperm to penetrate through the egg shell or fertilize. It's also more likely you'll make a genetically abnormal embryo that either doesn't implant in a uterus or that results in a miscarriage. So quality is really important, and that does decline with age. And the decline is a faster rate as we approach our late 30s into early 40s. Now, quantity, we kind of think of as number of eggs, and that also declines as we age. And that rate of decline, like quality, is faster in our late 30s, early 40s. Next slide, please. So because of this decline, you're never really too young to do this. Unfortunately, I think as people enter their early 40s, then it becomes more difficult to generate a sufficient response and high quality eggs. So you're never too young. And I think any woman who's a little bit interested should come to these sessions, book an assessment with us, just to get more information so you can understand this amazing service. Next slide, please. So I kind of just mentioned this. So assessments can be a 30-minute, 60-minute consultation. They can be with one of the REI physicians like Dr. Adams or myself. It can be virtually, so you don't have to be in a city with a Vios or KindBody clinic, although there are a lot of cities with Vios and KindBody clinics now, which is great. And what goes into the assessment is, number one, a discussion, kind of talking about what I'm saying, how quantity and quality matter. We talk about the different components to your ovarian reserve. So I gave a couple out just now. We'll also do blood work to look at one of the components of your ovarian reserve, and you'll get a transvaginal ultrasound. So that is to look at your ovaries, specifically the follicles that we're seeing on the ultrasound. We use to assess the broader storage in your ovaries unit or storage unit. I like to think of the analogy of if you lived in a home and in your basement you had a lot of boxes of different storage items, and then every month you would bring a box upstairs and look inside your box to see what you like to store. Are you a hoarder? Is your box really full? So when we do the ultrasound and we look at the follicles, that's like us looking in the box, which is your ovaries. So do things like that, and it's a lot of counseling. In a good way, it's a lot of hand holding, and you can book it at any time on the portal. It's really accessible. Next slide, please. So what goes into egg freezing? It involves shots, as Carly or CJ and Sophia have mentioned. They're shots every day for about 2 weeks. So we basically take over the first half of a menstrual cycle, and we'll get into all the details later. I don't want to throw out too much jargon there, but it's a 2-week process. That's it. And we see you pretty frequently in that 2-week time period, and then it will ultimately end in an egg extraction at the end of the 2-week period. You can freeze these eggs indefinitely. They are in a freezer. You don't have to use them, but you can. It's a really great insurance policy. Next slide, please. So who should consider egg freezing? And really, I think anyone. If I would say any woman should consider egg freezing. You can be married, you can be single, you may not know if you want to have children, you don't even need to know the number of children you'd want to have. I think any woman would find this empowering if they came and learned about their bodies, learned about their reproductive health care, and knowing that you can have a little bit of control of your future family planning is really special. Next slide, please. So we kind of talked about this. How does egg freezing work? We assess your ovarian reserve. Am I taking over for you, Dr. Adams?
Yeah, no, I was like, it's always so excited. No, thank you.
Sorry. Yeah, you do it.
Yeah. No, the whole point of doing egg freezing, as Dr. Dana eloquently said, is really to just empower you for your future. It really doesn't matter what age you are. It's really a comprehensive discussion for you personally. And it can be for that first child, that second child, that third child. Really, our mission is for building families. I think oftentimes people just think about one pregnancy at a time, but I personally ask my patients, and Carly can probably tell you, is like, how many kids do you see on that Christmas card that you're sending out? Like, what is the family that you want? We want to build that for you. So in terms of the egg freezing process, to go a little bit more in depth, For the most part, for timeline, usually your first month is your assessment, just like that Dr. Dana said, and that is your consult with the doctor, as well as your ovarian reserve testing. And the ovarian reserve testing is blood work, as well as an ultrasound. That is typically done when you're on your period. Now, if you Google things, it's cycle day 3, but it can really be done anywhere between the 2nd and 5th day of your period. And for those individuals that are out there, birth control pills, have IUDs in place, Nexplanons, etc., just let us know that you have those hormones, because we can let you know at what time you can do them. Now, again, in terms of that ovarian reserve, the blood work and the ultrasound is done during that time frame. And usually even within the first month, your doctor would be able to follow up with you in terms of saying, where are you at in kind of that reproductive timeline? Because like I said, everyone is an individual. We give you all these numbers and percentages, but we really want to know about your ovarian reserve, how many children you want, your timing. So once you get that ovarian reserve done, then it's kind of scheduling the timing. You know, the most streamlined thing, you could actually do a month of like evaluation consults, and the next month you can do your egg retrievals to get your eggs out. But there's some individuals where, you know, July could pop up and you're like, I'm actually going on a vacation in July. I would like to do it in August or September. You can do the time frame either right behind it or have a time between it. So once you get that done in terms of when you are available, that's when you kind of schedule everything. During that scheduling time, you will meet with the nurses. You'll get a follow-up in terms of the timing of the injections, when you're going to be seen in the office. They'll tell you the approximate time of your egg retrieval. Now, we can't tell you exactly at the very beginning, but we give you an estimate, and then talk a little bit more after the retrieval about how many eggs we got out. If you want to do this again, how many babies would that potentially be? And then kind of your timeline for pregnancy, if you will, when you're ready for pregnancy. Next slide. So, you know, again, like I said, first month is really evaluation, finding out where you're at. The second month can be, if you're ready to move forward, it's kind of the schedule, the injections. So we use hormones, and they're injected, typically subcutaneous or under the skin, to help stimulate the ovaries to grow multiple eggs. Now, you know, in a typical month when we're not taking hormones, most women will only grow or mature one egg. As Dr. Dana said, she uses the word, you use a box metaphor. We use champagne. So your ovaries like a glass of champagne. Every single month, you can only use the bubbles on the top. The rest are dormant, but each month you get a new set of bubbles. So you're just taking the little bubbles off the top, not affecting anything else. So what you want to do is look at the ones that you have available for that month, and you want to see how they can actually grow. So these injections help those eggs to grow, not just one, but, you know, 2, 3, 4, 5, 6. If you have 15 or 20, we want those all to grow and kind of grow at the same pace. And if we do that, we need to monitor you very closely. So during your calendar, which I'll go on over in the next slide, you're seen very often in our office, kind of every 2 to 3 days for monitoring, which always includes usually an ultrasound, just to make sure things are growing appropriately, as well as blood work to make sure your hormones are going up appropriately, to show us that we have eggs that potentially would be usable or viable. Now, in terms of when you're seeing that, again, that's when you have to be available. On average, most people are kind of around 10, but I would say the true gap that I've noticed in my patients is usually somewhere between 8 and 14 days. So you need to be available for multiple appointments, kind of every other day, every 2-3 days, over kind of a 8 to 14 day period of time. But some people mostly on average are in the middle at 10 days. Next slide. In terms of the overview, most people will get a nice calendar. As I said before, we can't tell you exactly where you're going to have your retrieval, but we give you an estimate in terms of when you're going to start these injections, when you'll come in for blood work and the ultrasound, and also our guesstimate of when you're going to have the egg retrieval. And as you get closer in the process, day 8, day 10, day 12, we actually will know the retrieval within 2 days. And then the last part of the stimulation, which is the injections to grow your eggs, is the trigger shot. And the trigger shot readies the body for the retrieval. And it's usually done about 36 hours beforehand. The nice thing of the trigger shot that I always tell my patients is that that's the end of the injections. Yay. You have a shot-free day, and then you have your egg retrieval the morning after that. Next slide. So, you know, how exactly does an egg retrieval work? So, you know, the procedure itself is very simple. I know it seems really complicated and it is very scary, but I mean, we do these every single day. They really only take about 20 to 30 minutes, but you are in the office for a couple hours. And the reason why is you come in and kind of check in and have your pre-op period of time, the actual procedure itself, and then we monitor you afterwards to make sure you're okay. Now, the egg retrieval is typically done under what's called light anesthesia. So you're not having, you know, general anesthesia in terms of being intubated or tubed down your throat. All the anesthesia is given through your IV. And for the most part, you know, I'll be very honest, I've done this procedure myself because I think it's very important to be a career woman and have power over your life. And if you want a family, when you want to have it, it's the best nap you're ever going to have. I'll just say it like that. So while you're sleeping, we extract or remove the eggs, and we do that transvaginally. So when your ovaries are big and heavy, they kind of fall down. So we use the ultrasound to actually identify the ovary, identify where the eggs are, and we use a very small needle to kind of suck the eggs out. You know, they're microscopic, so we always hand them over to our embryologist. They actually can identify and let me know whether or not we've gotten eggs. Once the procedure is over, we have you recover, and before you go home, we let you know how many eggs we have. Next slide. In terms of, again, a big question people always get, we're talking mostly about egg freezing for this talk, but really it's about fertility preservation. So preserving your fertility for the future. We said age is a big thing in terms of quality and quantity of eggs, and everyone has a different stage in which they might proceed with this. So the question is, should you do eggs for preservation, or should you do embryos? Now, usually you have to ask yourself a couple questions of which one is best for you in terms of your expectations. So obviously one is, do you have a male partner? If you don't have a male partner, obviously a lot of times you can freeze eggs because you don't have sperm. You have to put sperm and egg together to have an embryo. But some individuals will have a partner and they know that they want 3 or 4 kids, but they're both, business people, or they work in medicine, or they have jobs and they want to do it right now so they can make embryos to bank for the future. Are there some individuals who want to be a single mom by choice and they know they're going to use donor sperm and not have a partner, so they may make embryos now versus eggs in the future? Other things you might want to think about is what you're comfortable in terms of your family planning. So some people say, I don't want to freeze embryo because I don't feel comfortable with embryos. I want to do eggs. Also, you want to look at things like your ovarian reserve. So, we always bring it up for our patients that are over 40. I think there was a question about whether or not, if there's a time that you're too old. So it's not that you're too old to do egg freezing, it's just expectations. If you get older, there's a higher risk of abnormalities. So you need more eggs to get an embryo, because eggs are not an embryo, they're a potential of an embryo. So some people might select, instead of doing eggs, to do embryos. So they actually know what's in the freezer, so they can feel more confident about actually having that child or building that family. And so we discussed that with your ovarian reserve and your H in your consult. And then the other big thing is sometimes people are concerned, because they do egg freezing because of potentially genetic disorders, family history, et cetera. If you know that's going to happen, the only way you can actually genetically test something is if you have 2 parts of your DNA. And to do that, you need sperm and egg. So some people may make embryos with their partner early because they have also genetic concerns, because you can do something that's called PGT, or pre-implantation genetic testing, that could tell you whether an embryo is normal or not normal, or carries like a disorder that you might be concerned about for your future family. Next slide. So kind of what comes next? As I said before, streamline for the time frame. You can usually actually do this in about 2 months if you really want to get through it. So the first month is just your evaluation, your consult with the doctor. The second month is actually the stimulation part and freezing the eggs or the embryos. And the third part is just following up with your doctor about when's the next steps. So when you freeze these eggs or embryos, they don't really have a shelf life. They are frozen in time. They are never going to age, which is why egg freezing and embryo banking is fertility preservation. So if you choose or select to have a child in your late 40s, or even we've seen some of these celebrities come back at 50, it's because they're frozen in time. It's from a period when you were younger and potentially have less abnormalities in your eggs. So you're actually keeping things baseline, if you will, without actually going through time. They're not aging. When the eggs or the embryos are frozen, they don't age in the freezer. They're frozen in time. So you can actually use them. There's no shelf life. You can come back and use them. Typically, we want you to come back for a consult for a month, just to kind of, again, talk about the timeline and kind of what you want to do in the timing of either creating embryos in the future or having an embryo transfer. Obviously our hope is always that you'll get pregnant on your own, but again, these can be backups, if you will, for a second, third, or even fourth child, because we want you, again, to build your family. That's what we're here for, to support you. But if you need these eggs or embryos, they will always be there for you in the future. Next slide. So in terms of like our location, like Dr. Dana said, we're kind of all over the place now as we merge and combine. So there's a lot of clinics that are around, one potentially hopefully in your local area, or at least one that would be close enough to you. We do a lot of these things virtually, and we do have ability to actually do monitoring at other locations where you can actually fly into a KindBody or BIOS location in the future to actually get the procedure done and kind of freeze or store your eggs or embryos. Next slide. So I believe that everyone that's here, we'll answer all your questions, but thank you for coming in tonight. We want to let you know that there's this wonderful fertility code. It gives you kind of $100 off your first visit, and you can actually learn a little bit more about KindBody and BIOS, the joint merger between the 2 clinics, and kind of make an appointment at these websites. Thank you.
Thank you, Dr. Adams and Dr. Danis, for sharing your expertise with us, and to Sophia and Carly for sharing your experience. We have gotten lots of great questions in the chat while you guys were presenting. So I'm just going to start asking away, and maybe we will start with you, Dr. Danis. Someone is asking, do frozen eggs still deteriorate the longer they are kept frozen? How long is too long to wait to use those?
Great question. And I think Dr. Adams harped on this. We actually think they won't age at all. You can use them in 5 years, 10 years, 15 years. indefinitely.
Thank you for that. And
Can I add a little?
of
So,
course you can add, of course.
Yeah, because I'm a big geek. I think wonderful thing about doing all this process is the fact that we have these wonderful people called embryologists, people who are in our labs. So the reason why there's really no shelf life or things do well is because we have great technology now in terms of how we freeze eggs and embryos. And it's through a process called vitrification, where they actually can dehydrate the egg or embryo and they flash freeze it. So when they thaw them in the future, the thaw rate's usually about, in the 90s. So they do really well in the freezer and they can survive no issues at all because, again, the way that we freeze them is a special way, a special technique. There's no slow freezing, ice crystals, etc. Yeah, there's no shelf life.
Thank you, Doctor. Thank you. And we have another question that I want to follow up with. Around what age is too late to retrieve your eggs for freezing?
Do you want me to answer this?
Oh, I mean, I think we'd agree on it. There really is, as we said, there's no latest age, if you will. The very first step is making a consult, then actually getting your ovarian reserve testing, which is that ultrasound and blood work, and then talking about probabilities. I mean, I get always tease around with other doctors around me that I use the word E. E is for expectations. Nothing is 100%, but if you can understand what you should expect from your eggs and your age, you try to make a goal of how many eggs you would need to have a child from that group. And then if that's something you're comfortable with, we can proceed forward.
I also just want to add, I think every person has a different insurance policy that they want to attain. Some people are happy with the 50% probability of a live birth in the future. Some people want to get to 80%. Some people are fine with 30%. So I think you have to ask yourself, what is your likelihood of wanting to use these eggs in the future? If you're thinking you're not in a relationship, but you're going to purchase donor sperm in a year and try to conceive through a more natural means, then do it. Then you may say, okay, well, I only want one child anyway, so I'm fine with this 50% probability. Mm-hmm. If you're someone who's like, I want a big family, I've always wanted one, I'm focusing on my career right now, I realize you need to be pregnant for 9 months and wait another year to get pregnant, so like I need a lot, I want a high probability, then you might be someone who wants to cycle multiple times. And if you're older, that's even more times. So it's not about like there's an age cutoff. You have to, like Dr. Adams, what she said, you have to look at your ovarian reserve, the AMH, the follicle count, and your age, because that will give us an idea of egg quality. And then also what are you comfortable with? What probability of a live birth are you comfortable with?
Thank you. I have another one here. Does the ultrasound need to be done at a specific time during your menstrual cycle?
So they're considered day 3. So we typically want you to be on your period, if you will, at the very beginning of your hormonal cycle. So if you're not taking any hormones, we typically have you call on the first day and we see you between days 2 and 5. And the reason why is because at the very beginning of your cycle, that's when we can see your group of eggs kind of pop up, the ones that are available for that month. For me, it's the bubbles on the top of the champagne. For Dr. Danis, it's the box that you bring up from the basement. So you want to kind of know that's when your baseline is. But that being said, some people are on continuous OCBs because you're taking power of your cycle. Some people have IUDs and they don't bleed. Some people have Nexpanons or doing NuvaRings. If you're on any form of hormonal contraception, you just want to tell the office that you are. And some of those times you can just come in because you're already at what's called baseline because your hormones are already suppressed, which is why you're not having periods. And then I think that someone pulled out there, for our PCOS patients, a lot of times you're not having periods either. So you might just want to come in so we can see where you're at. And then we can let you know if you need to repeat it.
Thank you. Someone else is asking, how many eggs are in a good batch to be considered successful?
I don't know if there's an answer to that. Like I said, I mean, quality really matters. So 10 eggs in a 32-year-old is very different than 10 eggs in a 39 or a 42-year-old. You're young woman. So there's no ideal number of eggs in a batch. And that all being said, the number of follicles that we see on your baseline ultrasound don't necessarily represent the number of follicles that respond to the hormonal injections. And that doesn't necessarily represent the number of eggs we extract and how many are mature and freezable, because we can only freeze mature eggs. And we usually end up getting a little bit of immature eggs.
Thank you. We have another one here. What happens if you end up not needing to use your frozen eggs? What are the options?
So, I mean, if you don't want to use your eggs, there always is what's called a disposition form that you'll sign. So you can always discard them because they're your eggs. And again, they're not an embryo, they're just half genetics. Some people actually choose to sometimes donate them as well. And it can be to other individuals or it can be done to research, but they are your eggs. And again, when we have you freeze them, there is always a disposition form saying that what happens if something happens to me? What happens if I want to get rid of these eggs? Who will they go to? So we always ask that up front. And again, that's something you initially sign, but you can adjust or change it depending on how you feel.
It felt like the most important document I've ever signed in my life.
Thank you. What are the typical risks for using frozen eggs at a later age, 40 to 50?
So it depends on what age you froze the egg, because the quality of that egg, the genetics of that egg reflect the age at which you froze them, not the age at which you want to use them. We don't really think the uterus ages, so you can be 50 and use your 35-year young egg. As we age, there's more likely to be genetic abnormalities in the egg itself, and the egg is also going to be at risk of making a genetically abnormal embryo. So there are risks with that. But as far as when you use them at a later age, it's all related to when you froze, because as Dr. Adams said, you're freezing them in time and it will hold on to that age indefinitely.
Yeah. And that being said, if you are over 45, 50, or 55, because actually the cutoff in the US for carrying a pregnancy is 55 years old, they would treat you just like you would if you got pregnant spontaneously on your own. Women over the age of 40 typically have additional screening, just like when you go for your well woman exam, where they look at your blood pressure, they screen you for diabetes. So oftentimes, to be completely honest, most women over the age of 40, whether or not do egg freezing or IVF, when you get pregnant, when you see your OB, they may have you see what's called a maternal fetal medicine doctor, or MFM. And that's just based on potentially other things you get with age. Which I said before, it can be like high blood pressure, diabetes, et cetera. But if you're young and healthy, and I use the word young because I consider it, yes, 45 or so, you're still very young. As long as you're young and healthy, we just want to make sure that you're going to tolerate pregnancy well. Now, if you have other chronic disorders like high blood pressure or diabetes, again, it doesn't mean that you can't carry a pregnancy. You'll just work with your OBGYN and a high-risk doctor to have a plan in place in terms of how often are you seen, how are they going to screen the pregnancy, how things are growing. So it's just another part of pregnancy. And again, those pregnancy guidelines are based on age, and they would happen if you were doing egg freezing, embryo creation, or you spontaneously got pregnant.
Thank you. How does male partner age affect outcome for using frozen eggs?
So we think sperm can show effects of age in a man's 50s, 60s, but before that, we don't really see an effect on sperm concentration, sperm motility either. So if you were to freeze eggs, thaw them, or essentially defrost them at one point in the future, then fertilize them with sperm, we would have to have a semen sample and only use the most motile or the strongest sperm. And it would be one sperm would be injected into one egg, which is called ICSI, intracytoplasmic sperm injection. So if the person is older and may have lower concentration or lower motility, we'd first know that by a screening semen analysis and then go from there. If the numbers were very low, then we'd have probably a conversation with one of our reproductive urologists. But fortunately with ICSI, or intracytoplasmic sperm injection, you really just need a few handful of really strong moving sperm versus a semen analysis can have hundreds of millions of moving sperm.
Thank you. We have another great question here. What are the side effects of the hormone shots and how long do they generally last?
Well, I would say in terms of the side effects for the hormone shots, I mean, you are giving yourself an injection. So I always tell people the first thing you kind of got to get over is the fact that you're going to put a needle through your skin, which, as Carly said, the very first day, you're like, I'm going to put a needle through my skin. Okay. Every single morning, I'm going to put a needle through my skin. So you can't have a little kind of pinching or poking or burning. The more you do it, though, you get used to, I guess, doing that injection. That being said, as the cycle progresses on, I'd say most people around midway through the cycle feel a little bit like a pin cushion. You can also have little bruises where you're giving the injections at. Other things is, we're trying to stimulate your ovaries to make multiple eggs. So your ovaries going from like the size of kind of like an egg to a tennis ball. So it's going to get big. Your pelvis is actually very small. So I would say the number one feeling that you have is bloating. I like to describe it as kind of Thanksgiving dinner, but you still got a piece of pie for about a week or so. Not again, that's going to hurt you, but you're just feeling a little bit bloated. So, you might not want to wear the tightest clothes. So, Leggings and athleisure have become very cute now in this time frame. So I'd stick to those things with elastic bands. And the summer's a great time because you can always wear a dress. Bloating is definitely kind of the most common things. And then otherwise, I always do people ask me about emotional things because we're all women and we know what our hormones can do. I would say some people get very sensitive during the cycle, and not sensitive in terms of they're going to be mad at you, but just kind of like a pregnant woman, maybe a little bit more likely to cry at a Snuggles commercial, if you will. And I always tell people after the cycle, because everyone loves estrogen and your estrogen is going to be high, when it does drop down in terms of your period, if you're a woman who has PMS, you will definitely probably have those symptoms.
One thing I want to add is, and I did this, I froze my eggs too. So, and I also got nervous with the shots, and I'm like, I said, Rachel, you can do a repeat C-section ×4. You can give yourself this stupid shot. But I think it's nerve-wracking, but we walk you through it. We have nurses that schedule visits with you. We have videos to offer you so you can watch them at home right before you do it. But about the emotional component, I think maybe it's not necessarily the hormones that do it, but this is emotional. Like, women don't grow up and hear from their families and their friends, like, you're going to grow up and have a job and freeze your eggs and do shots every day and have an elective surgery. Like, that's not something we think about, but there's this societal pressure to manage career and family. So I think like that reality and realizing that it might be tough sometimes to have it all, yeah, that's burdensome and emotional, and it's okay. Like, it's okay to be emotional.
Thank you. Does PCOS decrease the chance of getting eggs?
No, it increases it, actually.
Yeah, it actually increases your risk of hyperstimulating or getting OHSS, or ovarian hyperstimulation syndrome, and which means you're at risk of having too great of a response where your estrogen is so high and you get bloated all over your body. Now, the reason why we bring you in so often in that 2-week period is because we want to make sure you're not reaching that point. So we want to make sure your estrogen level in your blood is not going too high, your follicles are not growing too quickly. And for women with PCOS, there are things that we do to circumvent your development of hyperstimulation, like putting you on metformin during your stimulation, giving you really low doses versus someone else who would get a higher dose, changing your trigger shot, or giving you a medication called cabergoline after the retrieval. So it's something we're used to dealing with. And yeah, it's more the opposite about getting too intense of a response.
Yeah, because I really personally don't like the title PCOS, because when everyone thinks of polycystic, they think cysts are bad. And a woman with PCOS actually has a lot of follicular cyst. So she has tons and tons and tons of eggs, but have hormonal imbalances that usually stop you from ovulating. So you have lots of eggs. You actually have a more robust reserve, which is why, again, we monitor you very closely. But yeah, it's definitely usually the complete opposite.
Thank you. Do fibroids impact the process?
Great question. They usually don't. At the time of your assessment, if you had a fibroid or a leiomyoma, if you had it close to an ovary, either because it was pedunculated, meaning it was sticking out of the surface of the ovary, or if it was lower down in the uterus near your ovaries, then it might just be about anatomy, and we'd have to probably push your uterus a little bit out of the way when we're doing the egg retrieval. Now, how Dr. Adams mentioned, this is the retrieval itself. The egg extraction is done with transvaginally. So when I say push your uterus out of the way, all that really means is we might give some abdominal pressure from above with our hand just to shimmy your uterus to one side or the other, which would also have the fibroid. Your pelvis is this one open cavity with bowel, bladder, uterus, ovaries, blood vessels. They're all just sharing the same space so we can move things around like a fibroid.
Thank you. How far before the retrieval process do you recommend prepping? Example, focusing more on nutrition and exercise, cutting out alcohol, etc.
I mean, I personally think it varies. You know, obviously, if you're an older woman, you're like balancing the time frame versus the supplements. I mean, if you look at most data, it's kind of a varying of like, if you can have at least 1 month, it would be the best, but some studies say up to 6 months. I would tell people if they have at least a month or two, meaning that from the time you start your consult to when you do it, you should be fine. That being said, sometimes we talk to people as people, not numbers. So if you have other things in terms of your ovarian reserve or history that make us think that we should take that extra 2 months to help with your quality or supplementation, we would tell you that. But I would say most people about 2 months, meaning the consult itself and right when you do it, should be a sufficient amount. And those things would include things like a prenatal, all the little micronutrients need, things like antioxidants, vitamin C. You want to be on things like fish oil or your DHA. There really is no true fertility diet, if you will, out there, but there's been some data that the Mediterranean diet is a little bit better. Less processed food, more whole grains, fresh fruits and vegetables. So kind of that.
Thank you. If I have the option to use frozen eggs, frozen at 33, and fresh eggs, assuming I still have them at age 38, which egg would you recommend using?
33.
Yeah, I mean, I would still say though, if you're 38 and you haven't ever tried to conceive naturally, I'd go for it. You may miscarry. And if you understand that, because your 38, your young egg is more likely to develop into a genetically abnormal embryo, as long as you understand that, I would say try to conceive naturally and use this for baby number 2, like your 32-year-old egg. But it's always nice to know you have a 32-year-old egg in the freezer.
Yeah. I mean, as we said before, age is the #1 predicting factor. And as Dr. Dana said, 10 eggs at 32 is a lot different than 10 eggs at 42. But again, it does matter if you've actually tried, because you can't really say you're infertile unless you've tried.
Thank you. Anything we can do to reduce the symptoms, pain, bloating, etc. in the process? I've heard that having a high protein / low carb diet helps.
So a heating pad will be your best friend, I would say, for the few days leading up to the retrieval until you get your period. But a high salt, high protein diet is important right when you get to the retrieval, and then for the few days, really a week or 2 after the retrieval, that salt and protein will pull all that water you're holding on to back into your bloodstream, so you'll feel better faster. But it's also a little bit of a waiting game.
Oh yeah, I was like, and another thing that no one ever wants to talk about, but all my patients know because I have to be very honest, is as Dr. Dana said, your pelvis is a cavity, everything's in there, but it's actually very small. So your uterus is like the size of your fist, and now your ovary is going to be the same size of that, and you have bladder and bowel. So bowels can be issues. So constipation is something that can make the bloating feel worse. So I usually always recommend patients, if they have any baseline issues with constipation or GI upset, to be on some kind of stool softener, increased fiber, because you don't want to be constipated. And for those out of you who have had one baby and thinking about the second baby, pregnancy in general with your hormones is a risk factor for constipation. So you want to make sure that everything's moving along. And again, being very hydrated with like water, coconut water, electrolytes, again, keeps fluids moving around. Again, just kind of getting off that water weight.
Thank you. Are there medications you are not allowed to take during the egg freezing process?
So a common medication that young women, or not any woman, can take is spironolactone or aldactone for acne. And I always tell patients to stop it. It blocks androgens in a few different mechanisms. And we don't actually know if and how much it would affect your cycle, but I would stop it.
I totally agree. Anything that really would affect your hormones. So like you can't be on, even though we may give you birth control before you start the injections, you can't keep like a Nexplanon in when you do a cycle. You can sometimes actually keep an IUD in, depending on what your ovarian reserve is. But like, Nexplanons, Depo have to be out of your system if you're going to stimulate. They may suppress things from growing.
But other common meds, like I get asked a lot, are SSRIs or SNRIs okay? They are okay, and I encourage you to continue taking them during your stimulation. Thyroid medications are okay. Hypertensive medications are okay, or antihypertensives, I should really say. Medications for any sort of neurologic disorder, please continue them.
Great, thank you. How safe and secure is the egg storing process?
I'd say it's very secure. I mean, everything's a little bit different. Within our clinic, within our offices, we have a couple clinics that have tomorrow tanks. Tomorrow tanks are kind of not only a 2-person, but a machine way where things are actually labeled by a person as well as a machine to where you can't even actually access them. In general, most people are concerned about eggs or embryos, but they're secure in liquid nitrogen behind lock and key. I always kind of tell people if anything in my office is open, my phone rings for more than 30 seconds. There's an actual a lock and key. There's only certain people who can get back to your eggs and embryos. And when things are moved out, when you're actually ready to use them, they're verified by 2 people, a computer system. You know, we have actual like hoods where you can't actually have more than 1 person on that hood. The computer won't work. There's all these different things that align it to where we actually know that these are your embryos, your eggs, they're safe. And again, only a certain number of people or a limited number of people can get back to them. You can't just walk into a lab and go to the part of the lab where people's embryos, sperm, and eggs are kept.
Great, thank you. One last question. Does autoimmune disease and being on immunosuppressants affect the egg freezing process or affect the quality of the eggs?
That's a really great question. Some data suggests that if you have autoimmune conditions like lupus, for example, you could have lower ovarian reserve. I don't think we know exactly how that would affect your egg quality. If you are having a lower ovarian reserve, you'd likely not respond as robustly to stimulation. But as far as a particular autoimmune disorder and a particular medication, we'd have to have a discussion about it. I think there's a lot. I mean, egg freezing is a relatively new science. So I would apply what we know about common autoimmune diseases like lupus to a broader autoimmune category. So yeah, I think it would just depend on your other ovarian reserve parameters. In a nutshell, though, we do think that you're potentially at risk or more likely to have lower ovarian reserve parameters.
Yeah, I completely would agree with that as well. Diabetes type 1 specifically, which is autoimmune one, has also popped up that we've noticed there's an association. Again, we don't have a causality, if you will, but there is associated that way. And then, you know, we take that in consideration with your reserve. Oftentimes autoimmune diseases and autoimmune medications, those ones affect implantation. So again, we bring that into consideration when we talk about when you want to use these eggs or embryos. But I would not say that they wouldn't preclude you for going through the process. You first have to make the consultation, see exactly what your ovarian reserve looks like, and then go through the actual stimulation medication to see what happens.
Great. Thank you so much. Thank you, Dr. Adams and Dr. Danis, for sharing your expertise. Thank you to Carly and Sophia for sharing your experiences with us. It's all very important. We appreciate you for being with us today. And thank you to everyone who joined us tonight. If you have any questions, make sure to DM us at Bios Fertility Institute or Kindbody, and visit us at kindbody.com or biosfertility.com to schedule a consultation. Have a great night, everyone.
Bye.
Thank you. Thank you.
Thank you.